بسم الله الرحمن الرحيم. أنا الدكتور محمد الشال، أستاذ ورئيس قسم جراحة الفم والوجه والفك والتجميل، كلية طب الأسنان. I am Professor Muhammad Elshall, Professor and Chairman of Oral and Maxillofacial Surgery Department, Tanta University. I will talk today about the differences for treatment of dentofacial deformities. This topic mainly concern with the different forms of dentofacial deformities and how we can treat them by the different surgical approaches, which we will discuss in this lecture. And this lecture is intended and delivered to the mainstream students and also the international dental students. That we are going to discuss some surgical treatment phases, like in mandibular excess. Mandibular excess in class 3 relationship. Different approaches ranging from osteectomy to subapical osteotomy and correction of local areas. Different techniques in which we can just cut vertically the ramus, subsigmoid vertical ramus osteotomy to cut the mandible and moving it backwards because of insufficient of the ramus of the bone. The ramus may be thin, that is difficult to be splitted, so we can cut it in one piece, either extraorally or now intraorally by the advanced technology and advanced methods of bone cutting machines or saw that is angled and could be used intraorally, could be done with different shapes of cuts, L shape osteotomy or C shape, plus or minus bone graft, in which if the bone is moved apart, we have to put bone graft in between to keep the bony contact and provide good healing. So we cannot moving bone segments away from each other more than 4 to 5 millimeter without putting a bone graft in between. But 2-3 millimeter is okay for maximum. The bone can bridge and can heal in that gap, but more than that we have to put bone grafts in between to guarantee bone healing and to avoid non-union or fibrous union and relapse or bad results. So we have to consider bone graft in any case of bone movement in considerable distance. This is the technique of sagittal osteotomy, sagittal split osteotomy, in which we have to split the mandible longitudinally and separate the lateral part of the ramus with the condyle. This part is called proximal segment, in which the condyle is still attached and is still in place in the glenoid fossa, and the part carrying the teeth is called distal segment, in which this part will be moved in different direction and then fixed in its new position by screws or bone plate until complete healing. And this case with mandibular prognathism done in our department, that's before and after, and this before and after mandibular setback and also with good occlusion. We can also make genioplasty and the cutting of the chin and moving the chin, cutting the chin below the mental foramina and avoid injury of the mental nerves, and moving the chin positions according to the treatment plan. It may be moved backward or anteriorly elongated or reduced according to the patient needs, like this case in which there's reduction genioplasty. This is before and after reduction genioplasty. In case of anterior open bite also, it could be treated by different methods, but a common method of treatment is selective maxillary impaction, in which the posterior part of the maxilla is elongated and pushing the mandible downward, producing clockwise movement and open bite anteriorly. By selective superior repositioning, removing bone from the upper jaw and pushing the posterior part upward, the mandible can move anteriorly to close the open bite. One common method, and also many other methods: subapical osteotomy, mandibular osteectomy. Many methods could be used also to correct this deformity. The most common technique in maxilla is the Lefort 1 osteotomy, in which we can make different movements, and also we have in some cases only we can do bone cuts in the anterior part of the maxilla in the place of upper first premolars, in which the whole maxilla is in a good relationship with the mandible, but the defect or the problem is only in the anterior part of the maxilla or the premaxilla, in which it is protruded or undergrowth. So we can cut only the anterior part of the maxilla and moving it in its to the normal position and fix it in this. This is called anterior maxillary osteotomy, which could be done by a buccal approach or palatal approach. So according to the scientist or the maxillofacial surgeon who firstly illustrated this approach, Vasmond approach, dealing with that from the palatal or dealing with cutting from the buccal side. Finally, we have to cut the premaxilla and we have to keep it attached to a considerable amount of soft tissue to maintain its blood supply, otherwise it may be necrosed and sequestrated. So we have to keep in mind always to have enough soft tissue attachment and soft tissue coverage to protect the bone from process, which could be done by a buccal approach or palatal approach. So according to the scientist or the maxillofacial surgeon who firstly illustrated this approach, Vasmond approach position. All of these, as I mentioned, should be done models, and this is the Lefort 1 osteotomy at the Lefort to correct the relationship. You have to cut the bone at that level and separate the maxilla completely, but it is still attached to the palatal mucosa and the posterior buccal mucosa, which could be done by a buccal approach position. We can remove bone, we can put bone according to the required position, and then after finishing we have to put bone plates in different areas to fix it in new position until complete healing, this case with maxillary protrusion and maxillary excess, and it is treated by maxillary anterior maxillary osteotomy and upward or with good results. And in facial asymmetry, we can do a lot of surgeries involving the maxilla, mandible, and chin to correct the position of the jaws. All these procedures and techniques used to correct the dentofacial deformities by the regular surgical techniques used in orthognathic surgery. After a break, we'll continue discussing other method of treatment of such cases using the distraction devices. That's called distraction osteogenesis, and we will compare both techniques, the regular orthognathic surgical procedures and the distraction osteogenesis in treating dentofacial deformities, and we'll talk for a while a little bit about obstructive sleep apnea, just to know this definition. What is obstructive sleep apnea? Just to know some information, some simple information about it, and also some information about distraction osteogenesis. And by this, we will complete everything about the treatment of dentofacial deformities. Now, let's continue the rest of our lecture about the surgical treatment of dentofacial deformities. Now we'll take a few moments about the definition of obstructive sleep apnea, one of the conditions in which we can use the surgical treatment of to treat small jaws restricted for tongue space, which affect the passage of the air into the trachea. This condition is called obstructive sleep apnea, is the occurrence of apneic events, breathing stop during sleep, such that a patient has cessation of airflow for more than 10 seconds. So when the patient sleeps, sometimes he cannot take normal breaths and there is a stop of breathing for 10 seconds. This is called obstructive sleep apnea. When this is repeated more than 5 times per sleep hour, it's called obstructive sleep apnea syndrome, and this can have a serious this is a serious condition that have some serious complications with time due to the chronic hypoxia during sleep hour, which could affect the cardiac function and the daytime activities, and may result in some cases, severe cases, may result even in death. So in such conditions, we can cut the small mandible and advance it anteriorly, which hold the tongue forward to open and to increase the airway space, facilitating the passage of air without obstruction. In this video, you can see the
If you
sleep
have
apnea definition.
obstructive sleep apnea, your breathing pauses for brief periods while you're asleep. Normally, when you breathe in, air flows in through your mouth and nose and down your throat, also called the pharynx. Air then flows down your windpipe or trachea, spreading through a tree-like structure of smaller tubes into your lungs. Each time you breathe in, negative suction pressure pulls the soft tissues in your mouth and pharynx inward. The muscles in your pharynx respond by pulling the lack of oxygen in your lungs wakes you up. You may gasp for air to loss of muscle tone in your pharynx due to aging.
So many causes
And
may
swollen
lead
tonsils,
to this obstruction of
irritability,
airway. One of them
and impaired concentration.
Is
Regular
the
heartbeats,
small
called
jaws,
arrhythmias.
which
Your
restrict
doctor may recommend lifestyle changes to
or
treat
make the
obstruction,
airway space small.
and
that
deviance may
condition, we
keep your
can-
airway open. This
Yes,
device
we can
works by pulling your
advance
jaw forward and moving
Remember
both your
that.
tongue and the roof of your mouth away from the back of your throat.
we can
Positive
advance
airway pressure or
the
seep
mandible
your nose
anterior.
and mouth.
Another method of treating such conditions is the use of the principles of distraction osteogenesis. And distraction osteogenesis means elongation of bone by cutting a horizontal osteotomy cut to separate the bone into two segments like in fracture lines, and by application of gradual distraction to separate this bone cut gradually through a definite period of time, the gap in between will fill with new bone, and the bone eventually will heal and form a new bone that results in elongation of the original bone. This principle uh, based on the gradual traction and the stimulation of osteoblast, which will form and lay down new bone matrix. Not only the bone is formed, but also the surrounding soft tissue, the nerve tissue, the muscles, the tendons, the cartilage, blood vessels, and the skin also will gradually stretched and elongated. This lead to the concept of distraction histogenesis, not only osteogenesis by formation of bone, but also histogenesis, which is a general name or broad name describing the elongation and formation of increase of tissue quantity of the whole surrounding soft tissue, not only the bone tissue. So by this gradual application of force which stimulate the formation of new bone, the new bone formed in the gap between the two sides is called the regenerate bone. After this regeneration, we have to leave the destructive device in place until complete calcification and remodeling of the bone in between to be able to withstand the normal forces. So we have some definitions, which is corticotomy. Corticotomy or osteotomy site is the initial cutting through the bone, which is called low energy osteotomy, with little force, with a small force, to maintain the vitality and the blood supply of the bone as much as possible, which is very important to preserve the new cells, the osteoblast, to form a new bone. So we will cut the bone to separate the two sides. This is called corticotomy or osteotomy. Then we will leave this cut in place. We will leave the tissue, will not apply any force until initial healing period to form soft tissue in between, which is called soft callus. It will take about 5 to 7 days, which is called the latency period. Latency period, after that, will apply force to distract the bone segments apart from each other according to certain distance. This is called rate. So the rate is the number of millimeters per day at which the bone surfaces are distracted. So we can distract the bone approximately 1 millimeter per day. And it's better to not to apply the 1 millimeter at once, but it's better to apply twice. So each time we can distract the bone by about half millimeter. This is called the rhythm. The rhythm of distraction is the number of distractions per day in equally divided increments that total the rate. That means the number of distractions which performed per day distributed not only at once, but it's better to be twice, in which the total number will equal the rate. Many applications of distraction, we can use either external distractors or internal inside the tissues, submucosal distractors, which is miniaturized or small size distractors that is applied now under the tissues. But at first it was large devices that should be applied extraorally above the skin by attaching rods penetrating the skin into the bone, and we still have some external devices that is used for large distraction movements, or in the cases in which we need extra force to be able to pull the osteomatized segments anteriorly, like in patients with cleft, in which there is a scarred soft tissue that limits the so we can apply this distraction device in many of the craniofacial reconstruction conditions, including orthognathic surgery, maxillary and mandibular lengthening and widening. We can use it also in cleft lip and palate patients for maxillary advancement in this difficult situation, and in some cases of after condylectomy or after resection of ankylosing condyle, now we can form a new condyle by forming L-shape osteotomy and elongation of the ramus to form a new condyle. We can elongate also the alveolar process in preparation for implant placement to avoid the use of bone graft in the side of atrophic alveolus. We can use it also after resection of part of the mandibular bone or maxillary bone in order to avoid also the use of large segments of bone graft and its consequence less successful outcomes. So we can use the distraction as in the form of distraction of bone transport segment, in which we can use the same bone of the same patient on the same area without getting away in another donor site. This technique of gradual distraction is based on Elizarov principle. Elizarov is a scientist, orthopedic scientist, who was the first to introduce this technique of forming new bone by gradual distraction with osteotomy, latency period, distraction rate, distraction rhythm, and consolidation period, in which we will leave the distractor in place as a retention mean or fixation mean until completing and consolidation of the for daily increments of 1 millimeter per day, and then this is after complete of distraction, and you can see the facial symmetry and the face is greatly improved. It was before like this with the occlusal canting and the deviation of the occlusal plane, and that after correction of the deformity, and they will go to excise the condyle. Many advantages of distraction over the regular orthognathic surgery, in which we can use it to produce larger skeletal movements, because in regular cases of orthognathic surgery we are restricted by the resistance of the surrounding soft tissue. So we cannot advance the mandible maybe beyond 10 millimeters, 12 millimeters maximum, because the restriction of elasticity of the surrounding skin, muscles, tendons, nerves, blood vessels, all of these will restrict the movement and will produce a larger percentage of relapse or recurrence of the condition. So we cannot move the mandible too much. But in distraction osteogenesis, we can move it larger distances, because the surrounding tissue will also respond to the distraction and will form new tissues, and it will regenerate in response to the distraction forces. We will eliminate the need of bone graft, as we use the same area to create new bone. Better long-term stability and less degree of relapse, less trauma to the joint, and decreased neurosensory loss. But the disadvantages, we need the full cooperation of the patient and his family in this procedure, and also the direction of distraction may be technique sensitive. It may not result in the optimal direction that we need. Sometimes it is deviated or abnormally created, so it is very sensitive, and it needs very close supervision and follow up. The need of 2 surgical procedures for placement and removal increased the cost of this technique, and longer the position of the jaws. All these procedures and techniques used to correct the dentofacial deformities by the regular surgical techniques used in orthognathic surgery. After a break, we'll continue discussing other method of treatment of such cases using the distraction devices. That's called distraction osteogenesis. The maxilla, it is very helpful in this regard. We can use it. And here we can compare between both the regular orthognathic surgery and distraction osteogenesis regarding some factors. If we compare the timing, orthognathic surgery should be performed after skeletal maturity to avoid relapse, with exception in severely affected function or aesthetics in childhood. So if we have a child with severe disturbance of function or aesthetics that make him handicapped or socially isolated, we have to treat this patient early in life with the possibility to repeat the surgery again after puberty. We have to inform the parents about that, but this exception we can do it early. In the opposite way, distraction osteogenesis can be performed anytime, especially in the children, in growing children. Regarding the gained distance, it is limited in orthognathic surgery by soft tissue envelope, while in distraction it is unlimited, and because it is gradually performed with regeneration of the surrounding tissue, distraction histogenesis. Post-operative relapse is present in orthognathic surgery to some extent, and it is very limited in distraction. Duration, orthognathic is rapid, short duration, but distraction is long. Patient compliance and patient cooperation, it is very acceptable in orthognathic because it is done once, but in distraction because it takes some time according to the distance needed. So it needs high patient cooperation. Surgical complication in orthognathic surgery, major surgery, so we expect presence of complications, while in distraction, less invasive surgery with less possibility of complications. Direction of movement in orthognathic surgery, you can do it in different directions. You can move the mandible anteriorly or backward, posteriorly, but in distraction osteogenesis, it's only one way movement, anterior movement in advancement, only in expansion, not in reduction or setback. The results obtained is immediate. The results are immediate in orthognathic surgery, but it is gradual in distraction osteogenesis. Now we finish all the related procedures needed to correct the dentofacial deformities, and we have to talk about the post-operative sequelae and post-operative complications. Of course, we will take a separate lecture about the most of the post-operative complications following maxillofacial surgical techniques, but we'll talk briefly about the post-operative events. As you know, we have two separate events could happen after surgical procedures. One is called post-operative sequelae, which these sequelae are the expected or inevitable events that occur post-operatively, such as occurrence of edema, bruising, limited range of motion, temporary neurosensory alterations. These events occur in all patients, but extent is variable according to the different responses. Edema is the result of trauma and injury to the tissues, to the cells, and increased vascularity of the area, and perfusion of the blood, and accumulation of the intravascular fluid after it penetrates outside the blood vessels to collect beneath the soft tissue, resulting in tissue swelling. So it differs from one to another person according to his sensitivity to the procedure and also to the way of management of the soft tissue and the surgical skills and the surgical techniques, but it is controlled by application of cold packs at the day of surgery and by the use of anti-inflammatory and anti-edematous drugs and corticosteroids for a limited period of time. It is not harmful, but we have to warn the patient about this event. Bruising or discoloration of the tissues, subcutaneous tissue, submucosal tissue, it is obvious in the face, under the skin. It is due to breakdown of the accumulated blood after accumulation within the facial spaces. So after surgery, you have to confirm the complete hemostasis and there is no oozing of blood. And if it happens, it takes about 1 to 2 weeks to completely resolve, but we have just to apply some cold application the first day and hot foments maybe later on until complete resolution of the condition. Limited range of motion due to affection of the muscles of mastication and trauma to the tissues, and also the joint may be affected. And in all cases, we have to just give time to the patient for complete healing and start normal movement and function. In all cases, during osteotomy, cuts, and trauma to the bone, there may be temporary alteration in neurosensory deficit that will improve by time. It will take a few weeks to early few months until complete recovery and complete healing, which is normal. On the other hand, the complications are unexpected events that may compromise or may affect the final result and they may disturb the successful outcomes of the surgical procedure and should be avoided and managed aggressively and early to overcome any permanent sequelae, any permanent destruction or failure of the surgical technique. Any type of surgery any type of surgery may have some risk of complications, and this may occur at any time during the surgical procedure, maybe during or after, and the most important is to know how to avoid the occurrence and how to manage this if it happens. Nerve injury you will have enough details about that, but the nerve may be injured. We have the inferior alveolar nerve, the infraorbital nerve. We have some degree mental nerve of injury during different surgical steps and surgical manipulation, which may range from just indirect trauma to the nerve transmitted by osteotomes, by tapping on the bone, which is neuropraxia or axonetemesis, in which some fibers may be affected to complete cut, complete separation, which will lead to permanent maybe deformity or permanent affection, in which we need to repair. We have to repair. We have not to wait more than 3 to 6 months of absence of all sensation, in which we have to revise and open the field to repair the defective or cut severed nerve, and in some cases we may need nerve graft to repair the cutted nerve. Sometimes we can get unfavorable bony splits. We can get fractured bone segments at unwanted sites. This unfavorable, or it's called bad split, may be due to improper placement of osteotome in the proper angulation, and we can also apply extra force that may lead to a fracture of bone segments. We can use too much force or inadequate bone mass. We can use a heavy force in areas in which there is a thin bone. So we have to be very careful during cutting of the joint may be also affected by a dysfunction or displacement of the condyle or condylar resorption, all of which due to improper planning and improper seating of the condyle in its normal place during fixation after repositioning of the osteotomized segments, and in that way we have to be sure that the condyle in its normal position before complete fixation. A hemorrhage may occur either during or after surgery, so we have to be careful in assuring complete hemostasis in the field before closure, and we have to put drains in which there is still some oozing of blood to avoid collection of blood within the tissue spaces, and we have to define the site of any oozing or escape of blood and deal with that by either local anesthetics, local hemostatics, gauze packs and pressure, or coagulation or tying or closure of the site of hemorrhage. Infection may arise due to excessive trauma to the tissues, bad handling of the soft tissue, depriving the area of adequate blood supply, and use of excessive heat without enough coolant system to reduce the bone temperature that may result in post-operative necrosis and sequestration of bone. We have to give adequate prophylactic antibiotics, and we have to control any systemic condition of the patient to avoid the presence of such a condition. And we have also to properly fix the bony segments to avoid the disturbance of healing, all of which will guarantee successful clean healing. The relapse or recurrence of the initial or less optimal results by movement of the segments again to its original position. This may be due to extreme range of movement of the bony segments beyond the capability of the surrounding soft tissue and inadequate fixation points needed to fix the reconstructed area in its good position until complete healing by using a rigid type of fixation. So many factors may have an effect on relapse, include type of fixation, magnitude and the type of movement, position of proximal segment, the proximal segment that contains the condyle. As I mentioned before, you have to be sure that the condyle is in normal position in the glenoid fossa to avoid post-operative sagging or dropping of the condyle and escape stretching of the condyle away from the glenoid fossa with post-operative relapse and disc displacement. By the end of the complications, we reach the end of this lecture. I think now you have a good idea about the different methods of management of dentofacial deformities and the different surgical techniques used, and we can compare between them, and we now can know how to plan the proper method of achieving the ideal treatment of such conditions. I wish you all the best and continuous improvement in your studying and in your life. Thank you. Assalamu alaikum wa rahmatullah.